All right. Um, okay, so without further ado, we're going to introduce our first speaker for the night, Dr. Chris Steven. You may have seen his Instagram reels or TikToks before. He's also an incoming PGY2 at Penn State PM&R. So, yeah, feel free to take it away, Chris.
Good afternoon, everyone. Thank you, Justin and Stephen, for asking me to speak to you guys. So I'm just going to share my screen now. Okay. Can you guys see that? Actually, I didn't share it yet. Hold on. Okay. You guys can see that, right? Okay.
Yep.
So I'm just going to be giving a quick overview on like what PM&R is. I remember, like, I personally didn't find PM&R until pretty much the end of my third year and had so many questions. I really didn't get all that much exposure over it. So I'm just going to give like a quick whirlwind of what the specialty is. But first, just some introduction. My name is Chris Duffin. I was born in Jersey. I went to Rutgers University in New Brunswick, in Jersey. I've been in Philadelphia for the past 5 years. I went to UPenn for med school, and then I matched into PM&R at Penn State. And so currently, I'm an intern resident physician at Lincoln Hospital, which is kind of like right outside of Philadelphia. So again, I'm in my intern year. I'm in month 10 of 12 of general medicine. A lot of people don't really like know pretty much like you don't match, you don't start in PM&R right after graduating medical school. Kind of like dermatology, like radiology, anesthesiology. You have to do a year of general medicine, kind of to get like a good foundation in medicine before entering your specific specialty. In a minority of programs, there are categorical positions where you'll do 4 years of PM&R with your intern year kind of more focused on PM&R. You'll still do a great deal of medicine, about 6 months of medicine. However, those programs are more of a minority. Most people do a year of internal medicine or they'll do a transitional year before moving into an advanced position within PM&R as a PGY2. So I have about 2 months left. So what even is PM&R? So in essence, it's a specialty that's focused on restoring function and improving quality of life for individuals with any kind of disabilities, injuries, or chronic conditions. And we specialize in non-surgical treatments for these conditions. A lot of people like to think of it as kind of like the non-surgical side of ortho with some neurology mixed in. And anyone who has any kind of problem with like moving around, it's this what I love about the specialty is that it's not limited by organ system or gender. If you have any kind of condition that limits your ability to move throughout your home, move throughout your community, playing sports, eating anything, uh, we help with that. And I think it's so important because your mobility is directly proportional to your quality of life. So, what kind of conditions do we even treat? So, some common conditions: strokes, spinal cord injuries, traumatic brain injuries, chronic pain or muscular disorders like MS, cerebral palsy. We deal with amputations and prosthetic training, getting patients kind of equipped with the prosthetics and helping them get through the process of learning how to actually use that prosthesis. Sports injuries and MSK conditions. However, the more you look into PM&R, the more you realize how broad it is. There are many other different niches that you can enter, like burn rehab, cancer rehab, pelvic floor rehab. There's just so many different areas that you can go into. And so I kind of spoke about the conditions and like what kind of medications are typically used. And this can change depending on the subspecialty within PM&R, but these are just some of the common ones that we use. So I spoke about conditions like stroke, MS, and you find that patients with upper motor neuron injury end up with the consequences of those injuries are increased tone and spasticity. And so we have a lot of medications that help deal with spasticity because if you can imagine having increased tone in your limbs impacts your ability to do your activities of daily living, like moving throughout your home. So you'll have medications like baclofen or diazepam. They work on the GABA receptors and they help kind of increase the inhibitory input and decrease kind of the increased tone, the excitatory muscle contractions. You'll have things like tizanidine, which is muscle relaxant, dantrolene. That's typically a medication that, like, as a med student, automatically you're like, oh, malignant hypertension. However, it also has its uses in spasticity, like decreasing calcium release from the sarcoplasmic reticulum. Gabapentin, pregabalin, those more so work towards neuropathic pain. TCAs or tricyclic antidepressants also work towards that neuropathic pain that you can see with like spinal stenosis or other kinds of nerve impingements. And then you have more common medications for pain, NSAIDs and opioids, which are of course used with like much caution. The next ones, things like Botox, ethanol, and phenol, that kind of moves more towards the procedural aspect of PM&R. Going back to the spasticity, you can actually chemically denervate some of the nerves that contribute to spasticity by putting in Botox. And typically we hear Botox in like the dermatology setting to kind of erase wrinkles from our face, but it could actually inhibit the neuromuscular transmission of the neurotransmitters within the junction, kind of stop that spasticity. You can also actually physically destroy the nerves as well with things like ethanol or phenol. And then, of course, you have corticosteroids. Again, that's more of like a procedural thing, putting the steroids into like joints, tendons, ligaments, or putting it into like the epidural space and decrease inflammation within kind of like the spinal cord that contributes to pain. So again, kind of talking about procedures, these are just a couple of images of procedures you could do in various different specialties within PM&R. This one right here, this is an epidural injection, putting steroids into the epidural space. And this is kind of a picture, a representation of what's happening here. Depositing the steroids within the epidural space. And typically you do it within the region of nerves that are contributing to back pain or lower extremity pain. And you'll end up with anywhere from like 1 to 3 months of relief with this type of injection. Right here, this is an example of Botox injection. This picture is ultrasound guided. However, you can also use like EMGs to make sure you're in the right within the right muscle. You're just depositing Botox within the muscles that are spastic. Right here, this is another pain procedure. It's a radiofrequency ablation, pretty much inserting probes adjacent to problematic nerves. And you'll use extreme temperatures, either like hot temperatures or cold, to end up destroying the nerves or ablating the nerves, and that'll lead to pain relief. And typically these are nerves that aren't contributing to any kind of motor function. It's primarily sensation. So you don't have to worry about losing kind of control of those like stabilizer muscles in your back. And this last image right here is the trigger point injection, which you can either do dry through like dry needling or injecting anesthetic in. So a lot of people have these kind of trigger points or these like knots in various different muscle tissues. They're like chronically contracted, inflamed, kind of painful muscle fibers, and you can decrease the contractions and the inflammation by like kind of poking it with a dry needle, as well as poking it and like inserting some kind of analgesic in. So I kind of spoke about what PM&R does, the types of meds and the procedures, but a lot of people kind of have trouble grasping like where PM&R fits in kind of medicine. A lot of you guys have like started clerkships and you haven't really seen where physiatrists or PM&R docs kind of work and how they help with patient management. So where do we work? So number one, inpatient hospitals. And so a lot of the times hospitals will have a PM&R department, although not all hospitals do. And in the inpatient setting, for the most part, I've seen physiatrists work as consultants. And so you'll have patients come into the hospital with all different types of conditions, whether it's heart failure, whether it's sepsis, whether it's like, pelvic fracture or whatever. And so a lot of times these patients, either they'll come in with some kind of musculoskeletal injury that they'll, speak with their primary doctor about. And so when this happens, the primary team can consult the physiatrist, and the physiatrist will come to the patient's room, get their whole interview, talk with them, and see what kind of recommendations they can make to the primary team in terms of managing that specific MSK condition. Other times it's because, as patients come into the hospital, especially when they're very old and they're dealing with acute illnesses, they'll become extremely deconditioned. And by the end of the hospitalization, although you've treated their heart failure, you've treated whatever like primary reason they came in for, they'll just be extremely weak from like laying in a bed for a long time. So the physiatrist will come. They'll usually, with the assistance of like PT and OT, will offer recommendations for patients to either go to like acute rehab hospitals or places like skilled nursing facilities. And so The decision between going to a rehab hospital or a skilled nursing facility kind of depends on how deconditioned the patient is, as well as how much rehab the patients can tolerate after their illness. So, rehab hospitals, of course, are post acute areas. Patients will go and they have to be able to handle like generally more than 3 hours of rehab a day for most days out of the week. And so they'll go there for a specific amount of time, and then after the rehab hospital, then they'll go home. Skilled nursing facilities, they'll get rehab for around like 1 to 2 hours each day, and not it's not as intensive as rehab hospitals, and it'll only be a few days out of the week. Other places physiatrists work would be outpatient clinics, kind of like neurology clinic or your primary care doctor clinic. Depending on the subspecialty, you'll have like pain physiatrists, neuromuscular physiatrists, like cancer rehab physiatrists. They'll work in an outpatient setting. They'll have their patients come in and they'll manage a variety of conditions. And then another place could be like on the field, the court, or the track for our sports medicine physiatrists. And so a question I get all the time from med students, from my family members, from everyone is like, what is the difference between PM&R and physical therapy? Like, what distinct things does each party do? Well, as a PM&R physician, you medically manage like everything about the patient. They'll come in, you'll manage the diagnosis, prescribe medications, you'll order all types of imaging, you'll do all types of procedures, and then you'll refer patients to physical therapy. And physical therapy is an important adjunct to the patient's care. And then once you send them to PT, the PTs will use different types of manual therapy, mobility, strength exercises, and education to treat the patients. And then kind of as the patients are receiving PT or after they get PT, they'll come back to the office and you'll further manage their care. And for the last slide, just different pros about PM&R that I've been able to appreciate. It's like super, super broad. You can subspecialize into so many different fields. There's so many different niches within each field. I've talked about a lot of the different subspecialties already. There's also great work-life balance, and patients are super appreciative. Kind of working in the acute hospital, patients will come in with like heart failure. You'll treat them with their acute illness, and they tend not to be like as appreciative. Although I've had so many appreciative patients, they just sometimes it just doesn't come across. But when I've worked with physiatrists and kind of being the doctor that helps the patient move again, helping being the doctor that helps them like return to the sport they love, returning to walking with their grandkids, they're just like super grateful for you, and it's always like lovely to hear. And I think that helps protect against burnout in a lot of cases. And that's pretty much it for me. You can follow me on my socials like Chris Too Cozy on TikTok or on Instagram, Chris Too Cozy MD. I've been doing like a PM&R playlist where I try to talk about different PM&R topics that people ask me. And I also just release all different types of kind of like humor, medical skits. So you can feel free to follow me if you want. And thank you.
All right. Thank you so much, Dr. Stephen. We really appreciate that. Uh, uh, we'll introduce our next speaker now. But actually, before we do that, we were going to do just a little bit of Q&A, just a couple minutes. If anybody had any questions for Dr. Stephen about his presentation.
Hey, Chris, I was just a little bit curious about, um, I guess what resources kind of led you down the path of PM&R and yeah, kind of how you got exposed. But like what kind of like built that exposure up and yeah, really made you decide to commit to it.
Yeah, so like I was talking about before, I didn't find PM&R until towards the end of my third year, the end of my clerkship year. And I just remember going through all my different rotations, kind of liking different aspects about each one. Like I like thinking about complex pathophysiology in IM. I like the anatomy of my surgery rotation, but I didn't really feel like I found something that I really like resonated with. And then towards the end of my third year, I was at a homecoming game at Rutgers. And I was speaking with like an anesthesiologist who happened to be there as one of my friend's mentors. And I was telling him basically everything I just said. He was like, "Oh, you should look at anesthesia." He was trying to recruit me to anesthesia, but he also mentioned PM&R off to the side. And so I was like, okay, I haven't really heard of PM&R. Let me look more into it. And so number one, I feel like as someone who has like a large background in like different types of sports, and during med school, I got into calisthenics and yoga. I just really appreciated fitness in my life and like mobility in my life. And I ended up like having an injury early on in med school, and I really came to appreciate how limited I became because like I wasn't able to walk as well as I wanted to walk. Additionally, as I was kind of going through my rotations, I saw patients come in and leave the hospital so deconditioned. I would sit and talk with them about the things that they really enjoyed, and they would say that, oh, I want to like play sports, they walk with my grandkids, but they left in a hospital in a state not being able to do that. And I always wondered like who was in charge of like what physician was in charge of getting them back to where they wanted to be, even though we did help them with their heart failure exacerbation. And so I looked more into it that way, read more about it. I really resonated with the philosophy of it. I shadowed with different PM&R doctors, saw how like what great relationships they had with their patients, and kind of like all that together kind of really resonated with the type of medicine that I wanted to practice. So that's pretty much how I came to find PM&R and like how it really kind of aligned with my ideals.
I also had a question. First of all, thank you for your talk. It was really informative. So I was wondering, like, since you were also in the Philly region, do
Mm-hmm.
you have any like I actually also even did like research at Lincoln now, so I'm like pretty familiar with the area. Do you
Mm-hmm.
have any like recommendations on how we can like go about pursuing PM&R opportunities in like that area of Pennsylvania?
Mm-hmm. So I think definitely getting involved with an organization like this, just looking at the spreadsheet that you were showing, Stephen and Justin, I was like, dang, I kind of wish I had this. I I think PM&R is close, it's such a close knit small field that not a lot of people know about it. And so reaching out to different physiatrists in the area would probably go such a long way because you'll find that most people like know each other in the field. And so that'll help with finding different opportunities. Also participating in different sports events like, the Broad Street Run, the Rocky Run, um, volunteering, you'll find physiatrists there who will help you with like networking and finding other opportunities. So definitely reaching out to them and participating in different events.
Thank you.
I can just add to that a little bit too. I would say doing an away rotation as a fourth year
Mm-hmm.
medical student. I don't know
Mm-hmm.
what year you guys are. Which year are you, Maha?
I'm a first year.
Oh, first year. Okay, so I don't know if you know what an away rotation is at this point, but you have the chance to do rotations outside of your um, f- um, your med school, so that's a good opportunity. This is like Chris was saying, this is a great place where you can reach out to residents, try to get involved in case reports. That way, there's always an attending involved at some level with those case reports. So you could try to establish rapport with them, maybe do like a little bit of shadowing too. I've seen medical students come through and do shadowing. So um, those are other things.
I also had a quick question. Dr. Stephen, thank you for your talk. So I know you mentioned that you kind of like learned about the field later on in your third year. So I'm kind of in a similar boat. I'm also like kind of near my third year, and I'm kind of just now kind of finding out about PM&R. So I was kind of wondering like if you had any advice for kind of like getting more exposure and things like that before application season rolls around.
Yeah, so things that I did to get more exposure, doing electives at my hospital. I found the PM&R student interest group at my med school. I joined it, learned about more opportunities there. I also joined other more broad organizations, kind of like just like this one. I'm not sure if you're familiar with SNMA as an organization. It's a med school organization. They have their own PM&R chapter that I got involved with. I went to AAPM&R, which is one of the national PM&R conferences. I started getting involved within PM&R research within my med school as well. And so I kind of went down all these different paths to kind of make myself more immersed within PM&R. again, I noted that this field is very small, close knit, and like one of the big things that residency programs want to see that you're actually committed to the field and that like you're serious about it. And the best way to show that you're serious is to be involved in all these different types of things. So I would definitely do things like that.
Thank you.
One final question I had. What were you kind of looking for in a residency program? Since there's a couple M3s in this group. So when you're like going down just the whole application trail, like what kind of like stood out to you in terms of yeah, where you wanted to match?
So a couple of things I looked at was like number one, region, although it's not really specific to it doesn't really tell much about like a residency program, but I wanted to stay in the area, so that was one of the limiting factors. Also, it really I looked at the subspecialties that I was interested in, one of them being pain or like sports and spine. So I went to find programs that had fellowships within um fellowship programs within the subspecialties that I was looking for, that I was interested in. Uh Also, just like feeling off the vibe of the interviews, trying to see how collaborative each program was, um, how like looking at the curriculum of each residency, how they broke down each year. Some programs and tend to be very like inpatient focused, while some other programs will have more elective opportunities. Some programs will be more procedural. Like you'll see residents from this program graduate with like this many EMG procedures, this many um, like other procedures. And so just you kind of have to find out like what you're interested with in PM&R and see which residency program tailors towards or better tailors towards that experience that you're trying to have.
Actually, Chris, I had another question just before we get to our next speaker. Given that we have some people that are going to be applying this year and that you just went through that process like pretty recently, a couple years ago, what would be your biggest piece of advice for people? Think something that you wish you knew now that you went through the application cycle.
Mm, that's a good question. Something that I wish I'd known prior to applying. I think I think I wish I'd done more away rotations. Um, just to gain more exposure within different institutions and probably I guess show face more. I feel like PM&R is getting like increasingly competitive, and kind of a great thing you could do to become more competitive would be actually working there for a month, creating relationships within each like different institution. And so that's probably something I would have done more. But other than that, PM&R tends to be like super holistic. Um, as long as you show an interest within the field, have things on your application that kind of support it, and kind of like have a good personality, whatever that means, I think you can be like really successful within the field. So yeah.
Perfect. Well, thank you so much. All that was super helpful. So we'll introduce our next speaker, Dr. Gordon Ridgeway, Chief Resident at MossRehab. Um, I'll let you take it away, Dr. Ridgeway.
Thank you. So make sure I got this set up. So yeah, I'm Gordon. I'm a PGY3, soon to be PGY4 up at Moss Rehab in Elkins Park, which is just outside of Philly, north of Philly. Um, I'm also the chief academic resident at Moss Rehab, which means that I'm uh, getting speakers for our didactics. We have every Wednesday morning, we have 4 hours of lectures. And so I, get those together, organize them, and lead some resident education, like journal club, things like that. And I'm also, most importantly, DuCom grad, so class of 2022 here. My talk tonight is going to be about spasticity. I think Chris did a great job of going through basically everything about PM&R, what we do. He talked a little bit about spasticity. We're going to dive deeper into that, more of a clinical aspect, with some theory behind it as well. But I wanted to keep it clinically relevant. I think that would be more interesting for you guys. I wanted to ask, and I would love to do some participation. I want to ask you guys questions, kind of see what you're thinking. If nobody wants to respond, that's fine. I'll give it a few seconds and move on. But I am curious what how the group is broken down. Is it mostly preclinical med students like M1s, M2s? Do we have a lot of clinical? Are there, I know Justin's an M4, but how are we spread out here? Do you guys know?
Why don't we have everyone put their year in the chat, maybe?
That'd be great. Yeah. Let me see here. M2, M3, M1. Great. All right. So we have a good mix. So yeah, I'll try to break this down, keep it at a level where it's engaging for everybody. But stop me if you have questions, please feel free. So I did this. Let's fast forward 10 years from now. Let's say that you are a physiatrist, you're a specialist in spasticity management. You get a patient referred to you. She comes into your office, tells you, my arm won't straighten out. Okay, that's all you got at first. And her PCP referred her. She tells you that she had a stroke. She probably won't say right middle cerebral artery, but she tells you that she had a stroke about a year ago. She was in the hospital. She went home. She's been just living at home, not working since then. So what questions do you guys have for her? You can unmute, speak, you can put them in the chat. I want to kind of get you thinking, and then we'll go through.
I would ask like when the stroke was.
So it was a year ago, she said. Is there any pain? Yeah, absolutely. The arm movement problem, yeah. No.
If it's in the leg too, or just the arm.
Of course, yeah, absolutely. Good. So you guys are getting thinking. What do we got? What things were you able to do before that you cannot do now or are most difficult? That's a great one. That hits on the key, which is function for us, right? So the first thing that I put is, as you said, pain. Sorry, my cat's playing with the arm behind me, which is excellent. Pain, and where's the pain, right? Do you have spasms, meaning like cramps? Is your muscle cramping up? What do you use the arm? I gotta grab that. I'm sorry, guys. Right there. You can't do that. Sorry about that. What do you use the arm to do now, right? So her arm is bent. Does she still use it to do anything? Maybe open up the refrigerator, maybe hold a piece of paper with that arm when she writes with her other arm. And we're assuming here it's the left arm because she had a right-sided stroke. What is most difficult for you? So let's say she tells us she can't get her shirt on by herself because her arm won't go up. Do you have a caregiver at home? What do they help you with? What do they do for you? What are you unable to do by yourself? What medications are you on? What medications have you tried in the past? Have you ever done any physical therapy, occupational therapy? Do you wear a brace? Have you ever received any injections? So there's a ton of questions. We usually have like standardized, note formats that we'll kind of go through those things. So on physical exam, moving to that important piece. We learn about in medical school, we learn about inspection, palpation, and then going through strength, sensation, special tests. So in terms of inspection, one thing we want to look for in this when we're thinking about spasticity is skin breakdown. So we can see here, I don't know what body part this is, but if her arm is bent all the time, right? There can be some skin breakdown at that elbow from moisture, some fungal infections as well. Same thing in the hand. So you want to open the hand, you want to look in there. Sometimes there's an odor, which is definitely a sign of some skin breakdown and possible infection as well. The armpit is another area. We want to look at range of motion, both passive range of motion and active. Passive meaning how far can I stretch them when they're relaxed, and active meaning how far are they able to move on their own with that arm. So strength, sensation, of course, and then spasticity. So spasticity, it's defined as a velocity-dependent resistance to motion. Velocity-dependent meaning that as you move that muscle more, as you move the joint more, that muscle engages and prevents you from moving it. So we're talking about the biceps, right? If I'm trying to extend the elbow like this, her bicep starts to activate and prevents me from extending it. If I move it real slow, we won't see as much of that. That's the true definition of spasticity. And we use the modified Ashworth scale very frequently to quantify spasticity. I'll come back to that.
Hey, Grant, so sorry to interrupt. Is it just me
Yeah.
or is it not in presentation mode? Is everyone else able to see it?
I don't think so.
Yeah.
I was gonna say so. Okay, there we go.
What's wrong?
So
Perfect.
I think you were it was stuck on the first slide and it wasn't in like the full presentation mode. So we weren't
Oh,
actually able to like see like each slide on the screen.
I gotcha. Okay. What if I do this? Do you see the physical exam? What do you see?
I personally don't. It's on the main screen. Do you happen to have two monitors?
I don't, but
Okay.
we'll just do it like this. This is
Yeah.
fine. I can just
If you
click
just
through.
yeah, if you just click through, that would be perfect.
No worries. Thanks for letting me know. So I was just, I basically was talking about all of these things, and then talking about the physical exam. So here, you see some skin breakdown there, and then the modified Ashworth scale. So a little bit of theory on spasticity. This is called the Brunstrom stages of motor recovery. I won't take too much time in going through it, but it's characterizing the typical recovery pattern after somebody develops a stroke or other upper motor neuron acute lesion. You start with flaccidity. For those of you that have done inpatient rotations in maybe medicine or certainly neurology, a lot of these patients who come in with acute strokes, their arm will just be limp. As time goes on, within a week or so, they'll start to develop a little bit of spasticity, that tightness, and then synergies. Synergies meaning they can move their arm, but they can't move individual joints one at a time. So if you ask them to reach out, they'll just kind of go like this. If you ask them to reach back behind them, it'll be this. So they're getting this elbow flexion, wrist flexion, finger flexion. That it all happens at once. So it's a very crude movement. Spasticity increases, and then everything kind of improves. Stage 6 is basically back to normal. The key here is that most patients, many stroke patients, don't reach all the way across this arc to stage 6. They may stop at 2, they may stop at 3 or 4. They often get past 1. They often don't stay flaccid, but it's just kind of a framework to think about how they're recovering. So let's go back to our patient. So like I said, she says that straightening the arm is hard for her, but getting a shirt on is also hard for her. And then she says she can't reach out forward. She can't get her arm up. She can't get into her armpit to clean it. So one thing that you guys can try to get familiar with as you go through your rotations and whatnot is the anatomical position and descriptions of how joints are positioned in space. So we have these 5 different figures here. So let's try to figure out which of these our patient is presenting with based on this description. All right, so, and we can all kind of you can do this at home if you want. Just turn your camera off if you don't want to show anybody, but I'll be doing it. So the left arm, the arm refers to the upper arm. is adducted, meaning it's against the body, and internally rotated. Okay, so that means internally rotated is reaching across the other side externally. The elbow is flexed to 90 degrees, right? The forearm is supinated meaning palm up. So we're here. The wrist is flexed and ulnarly deviated. So that ulnarly deviated means towards the pinky. So the wrist is kind of this way. It's flexed like this. So we're here. The fingers are flexed at the metacarpophalangeal joints, which are these, and the proximal interphalangeal joints. And the thumb is in the palm. So we're looking at this one, which you can see is pattern 1 there. And the reason that I took the time to go through all that is because you'll see notes like this, and it's good to be able to just imagine what is being described. And the other thing is that each of those motions or positions is caused by some overactive muscle, right? And so soon, eventually, we're going to get to what we can do about it, and we want to be thinking about what muscles we can target to treat her condition. So now let's talk about the modified Ashworth scale a little bit. It's a quantitative descriptor of spasticity. It goes from 0 to 4. There's a 1 and a 1 plus. So in my presentation, I had like animations where the 2 Ashworth scales here would have appeared afterwards, and I was gonna quiz you guys and make you tell me what they were based on the descriptor, but you're spared from that. So let's talk about the shoulder again. So resistance throughout passive abduction of the shoulder. Abduction is like this. Passive abduction means you're taking the patient's arm and abducting it away from the body. There's resistance all the way throughout that range of motion. And there's a soft stop at 90 degrees. Soft stop meaning it gets tight. You could crank on it a little more, but if you start to pull much beyond that, it'll hurt her. As opposed to a hard stop, which tells you that there's probably some kind of bony impingement that you might see in osteoarthritis or other bony abnormalities. So that's the shoulder, and it turns out that would be described as a modified Ashworth scale, which is MAS of 2, which means there is significant resistance to passive range of motion throughout the entire range of that joint. At the elbow can be flexed to full range, so we can get her all the way into full flexion. We can get her extended to 90 degrees, at which point a catch is felt throughout the rest of the range of motion, with a hard stop at 150 degrees. Now, a couple things to break down there. So we get to that 90-degree mark, we feel a catch. A catch refers to that biceps or the other elbow flexors like brachialis engaging and resisting our passive stretch. We feel that throughout the rest of the range of motion to 150 degrees where there's a hard stop. That tells us that there's some degree of contracture there. Contracture meaning that the tendon has shortened, or there's bony abnormalities preventing any further range. Spasticity medications and Botox are not going to help with something that has a hard stop. So that's just important to know when we're talking to patients about goals and expectations. And that elbow flexor modified Ashworth scale that I just described, that would be a 1+. So you can get them to beyond halfway, and then you feel that catch throughout the rest of it. So management options, there's a ton of things that we can do for this patient, and there's a ton of things that need to be done and should have been done before, by the way. She's been living at home for a year. She's been developing that spasticity. She's got some contracture in the elbow, and she hasn't been doing therapy. She hasn't been bracing. She's not on any medications. It's not her own fault. But as patients leave the hospital following a stroke, they come to acute rehab, they get plugged in with a physiatrist, and we do all these things to hopefully prevent some of these complications. But this does happen where we have chronic stroke patients come in, and we try to improve them as best we can. So we're going to get her into an occupational therapist. they're going to help her figure out how she can get on her shirt. Should she put the fist through the shirt hole first, or should she lead with the elbow? Should she be using button-down shirts or t-shirts? All these considerations they're going to help her figure out just to make her daily life easier. They'll also work on strengthening the available muscles, like maybe strengthening the triceps, right, to overcome that biceps. Bracing, like you see here, this is keeping the hands and the fingers and wrist in extension so that she's not worsening that contraction. We will be the ones that prescribe the brace and will tell the OT what kind of brace to give her. Serial casting, I won't talk about for the sake of time, but another treatment for contracture, actually. And then medications, right? So oral antispasticity agents, Chris talked about baclofen, dantrolene, tizanidine, less commonly benzodiazepines, and even gabapentin, more so in pediatrics. And then the focal antispasticity treatments. Focal meaning you're targeting a specific muscle. So chemodenervation, which is botulinum toxin, or chemoneurolysis, cryoneurolysis, which uses phenol or ethanol to actually break down the nerve that is supplying that muscle so that the signal is cut off. Because think about it, the spasticity comes from a disruption somewhere before the lower motor neuron where the cortical inhibition of muscle contraction is lost. So if we cut that lower motor neuron, then the overactive signal is not going to get to the muscle. So just a little bit, Chris mentioned this, it's Botox inhibits acetylcholine release at the presynaptic nerve terminal. Acetylcholine is the neurotransmitter that induces a muscle contraction. So no acetylcholine, no contraction. That's why botulism is deadly, because it paralyzes the diaphragm. We're using a very small amount, so it's not going to paralyze the muscle completely, but weakness is a side effect, of course, which is also the goal. Botox is the most common brand. Others are Dysport, Xeomin, Myablock. They're all basically the same toxin, just different formulations, different brands. In terms of the duration of treatment, 3 days till onset. So, you inject them on day 1. They'll start to get effects of it at about day 3, day 5. It takes about 3 weeks to reach its peak, sometimes a month or so, So when we do injection for the first time on a patient, we usually want to have them come back in about 4 to 6 weeks so we can see how they look at the peak of their effective treatment. At that point, we'll reassess and then plan for another treatment in 3 months from the point of treatment. So another 6 weeks or so from that second appointment, and we can modify our plan. We can change the targets. We don't treat less than, I think 84 days is the FDA approved number, but we don't treat less than 3 months, which is 90 days or so. The reason for that is because if you do it any sooner, you run the risk of the body developing antibodies to botulinum toxin, the antibodies would go in, they would break down the toxin right away, and it wouldn't have any effect. So it's not like they would have an allergic reaction or something. It's more the medication would be ineffective. And then we always have to talk about adverse effects with our patients whenever we do any kind of procedure or order a medication. So with any injection, there's the risk of local irritation, infection, bleeding. Distal spread is a very low risk phenomenon, but it's something that patients should be warned about. So if we accidentally inject into a blood vessel, the toxin can spread throughout the bloodstream and end up landing somewhere we don't want it to. God forbid, the diaphragm or the pharyngeal, laryngeal muscles. This is very rare. I haven't seen any cases, but some attendings will say they've seen it once or twice. In terms of muscle selection, so this is probably the most important thing, right? And that history that we got earlier, as well as the physical exam that we performed, is going to help us determine which muscles to target. So in our patient, She has a ton of trouble getting dressed because she can't lift her arm up. She can't abduct her arm, as well as cleaning her armpit for the same reason. And then we know that her chief complaint, her main concern was that she cannot straighten her elbow. And then we also saw some skin breakdown there in the elbow. So here's another one where I was going to ask you guys, what movers would you want to treat? And I said movers because, we're just thinking about what movements we want to inhibit or allow more of. I'm not as worried about the muscles. I'll get into that. But, so you want to treat the opposite of those things that she cannot do, meaning if she can't abduct, it's because her adductors are overactive. So you want to weaken those. She has her arm is in internal rotation, so we want to weaken those. The elbow flexors are preventing her from straightening her arm, so we want to weaken those with the Botox treatment. So I did a little bit of anatomy here. The internal rotators and adductors, turns out that they're more or less the same. There's some separate ones, but overall, it's the same. It's these three major players here. So pectoralis major, it has two heads. It has the clavicular head and the sternocostal head. It inserts onto the humerus in the anterior portion, and it's gonna the clavicular head has some flexion, right? But the sternocostal head is more of an internal rotator and a strong adductor. The teres major, similar, internal rotator and adductor, that's just posteriorly. And then the latissimus dorsi is the very large muscle in the back with many of the same actions, as well as shoulder extension, which is pulling the elbow back. Something that might come up on your exams or, down the road in your anatomy courses, there's this, a lady between two majors mnemonic. I thought I'd throw it in there. So that's talking about the insertion of these three muscles around the bicipital groove. So the lady is the latissimus dorsi. That inserts in the floor of the bicipital groove in the anterior humerus. The pectoralis major inserts most laterally, so the lateral edge of the groove, and the teres major inserts on the medial edge of the groove. So hence the two majors and the lady between. So you may ask, what about subscapularis? That's an internal rotator as well. Well, a key thing that you'll come to see is that subscapularis is one of the rotator cuff muscles. The sits muscles is the mnemonic for that. And these muscles we tend not to touch. We don't want to weaken these because the shoulder is really a muscular joint, meaning that these four muscles really hold the humeral head into the glenoid fossa. And if we weaken those, we risk shoulder dislocation or subluxation, and that can lead to pain and instability, and we don't want to do that. So I've seen it treated for sure if it's super overactive, but much less so. So let's go down to the elbow. Bear with me here. So the elbow flexors, there's three main muscles at play. The first one that comes to mind, I even used it in my examples earlier, but is the biceps. But the brachialis is actually the primary flexor of the elbow. It acts with the muscle, with the wrist in supination, neutral, pronation. It's probably always going to be the first muscle to fire if you're just lifting up your phone. If you need to lift up something heavier, then you're going to recruit the biceps, the brachioradialis. But the brachialis, it's a high yield fact, is the primary flexor of the elbow. That's why I said first muscle to fire here. The biceps is also a supinator, very strong supinator. That's the biceps' primary motion. It actually inserts into the medial aspect of the radius, and you may have seen it in your anatomy courses. It inserts down there, and the first thing it does is pull the radius up, which turns the wrist up. So in our patient, right, the clinical relevance, her arm was supinated, so the bicep, that's a clue that the biceps is probably overactive there. Brachioradialis primarily acts with the wrist in neutral position, which is thumbs up like this. and it inserts distally near the radial styloid. So those are our elbow flexors. So we have an idea of what muscles we want to target now. How do we know when we're actually lining up to do the injection, we are in the right muscle? And it's another thing that Chris talked about. So first of all, we should know our landmark anatomy, meaning our surface anatomy. The biceps is a pretty easy one to target. In somebody like our patient here, we're going to see that muscle belly. It's going to be firm, and it'll be pretty obvious. But you can start to get familiar with how to target the muscles, whether you see them active or not. EMG means that we take a needle electrode, we insert it into the muscle, and we can hear the motor units actually firing. In an overactive muscle, they'll be firing even at rest. If we're not sure, we can stretch the arm, and then we'll hear it firing due to spasticity, right? That velocity-dependent engagement of the muscle. Electrical stimulation, that's actually a really satisfying one. It's useful in muscles of the leg, like the calf muscles, where, let's say, like the toe flexors. The leg it's a bulky, limb. It's hard to see exactly where you are for sure. But if you put that needle electrode in there and then you turn on electrical stimulation while you're in the muscle, you'll see the big toe flexing, and then you're there. And then you go ahead and inject. And then ultrasound is another big one, getting more and more popular, I would say. So here's an ultrasound of the arm, and I think you guys should be able to see my mouse. So here's the humerus. It's called hyperechoic, is what we use to describe the bright images. And then this is, the body of the humerus. The biceps is the more superficial muscle belly. It's this kind of oval shaped. Here's a fascial plane between the biceps and then the brachialis. Yeah, brachialis is kind of this triangular shaped deeper muscle that's like upside down U wrapping around the humerus. So you would just go ahead, you put your needle right in there, you would see the needle, and then as you inject, you can keep the ultrasound there, and you'll actually see the fluid from the medication filling up, creating a little fluid pocket. So again, satisfying to see. All right, so let's wrap this up. We make a plan for this patient. We treat her with 50 units of Botox to each of the pectoralis major, the teres major, the latissimus dorsi. We do 75 units to the biceps, 50 to the brachialis, and 25 to the brachioradialis. And an occupational therapy script. I put that in cap because that's going to be like more important than anything else we can do, I would say. So we give her 300 units, which is a pretty good dose. 400 units is the max that you can do for the upper limb. She comes back 6 weeks later. She has great relief in raising the arm. She's able to get it up much better. She's also extending the elbow a lot better, and we're really happy to see that. But today she's telling us that she can't open the hand. So I said to be continued here. I don't know if we'll make this a series, but there's a lot more to talk about, and I'm happy to do so. But we'll stop it there. And any questions that you guys might have, if I didn't put you to sleep.
No, thank you so much. That was super thorough. I think it's really helpful, especially for the earlier, like for the medical students earlier in their career to understand some of the anatomy and which muscles you target. So that was great. One thing that I also kind of thought would be super helpful for you to touch on is when you would maybe not treat spasticity, like when would it actually be like functional for the patient to have it?
Yeah, that comes into play a lot in the lower limbs, I would say, particularly in the weight-bearing muscles. So I'm thinking quadriceps, which is the knee extensor. So that's one that we are very cautious when we treat, and we really have to listen to the patient and their history. If they're telling us, they wake up in the middle of the night and their knee stiffens up and it's super painful, and then we watch them walk and their quad is super strong, there's no buckling, then we can go ahead and give them a little bit into the quadriceps. If they're not having those complaints, and we watch them walk, and and then we do an exam, a manual muscle test, and spasticity, modified Ashworth exam, and we find that there is spasticity, but we watch them walk and they're able to bend their leg when they walk, or we see a little bit of knee buckling during stance phase when they're walking. Then we would not want to treat that. So it's in the upper limb, if it's a concern for them, definitely, I would say it's good to treat. In the lower limb, I think we need to be a little bit more judicious because the biggest thing is safety, and the lower limb is preventing falls. So we want to avoid that at all costs.
Yeah, that definitely makes sense. Does anyone have any other questions for Gordon?
Hey, I actually have one quick question. Thank you for the talk, by the way. But in your opinion and experience, has there been any strong benefits or good protocols for preventing spasticity, especially in stroke patients? Or what are some good things to do at least?
Yeah, absolutely. Spasticity is a naturally occurring phenomenon. It's thought to be sort of an evolutionary mechanism to prevent falls. Um, it's maladaptive, of course, but it can happen, and in many patients, it will happen. Early stretching, bracing, um, using the muscle, and medications, if we notice a little bit of spasticity, can help get on top of that. I would say bracing in particular is one that we do a lot in acute rehab. So, they'll come from the hospital, they just had a stroke a week ago. And let's say the occupational therapist notices that the hand is starting to tighten up. Every night when they go to sleep, we're putting that patient in a wrist extension, finger extension brace that is going to prevent that hand from just being closed all night. And that's going to help to keep it open. So it's going to happen, but we can prevent the muscle shortening and the really overbearing spasticity pretty well. And the other thing I would add to that too, as consultants, Chris talked about we have a role in the acute care hospital as consultants. If we see a patient in the ICU who had a severe stroke and they're curled up like this, that's something that we can get right on top of. We can talk to an occupational therapist, have a brace made for them. We can put them into all kinds of different positions. We can have weight shifts, things like that, to try to prevent that, because they're going to wake up and be wondering what happened to their arm.
Anybody else have any questions?
Hi, I also had a quick question. Thank you for your talk. In patients with very diffuse spasticity, do you find that like oral medications versus like specific chemodenervation, do you have like a preference for using one versus the other?
Yeah, it's a great point. I thought to mention that in my talk, but I did not. So thank you for bringing it up. We were looking at a patient whose symptoms were mainly in one out of the four limbs. There's a limit to how much Botox you can use, and if it's all four limbs, then we're not going to treat her. So exactly as you said, we would want to start something like baclofen. The other thing that we can do is refer them. We can have talk about a baclofen pump, which is an intrathecal pump that's delivered much higher. It's a very low amount of baclofen, but it's delivered directly into the spinal cord, bathing the spinal cord, and that's going to have a much more systemic effect. So yeah, absolutely.
Anyone else?
Yeah, I also had a question. Thanks for the presentation. I really like the case-based approach. But I was wondering, you were showing I believe it's called the Brunstrom like stages in terms of how strokes develop. Is there any way we can like prevent like spasticity from developing in along that stage?
I mean, it's like I was saying, I think it was maybe James's question. Um, you know, it the patient, the human body is going to follow its own trajectory in terms of that recovery, and it will try to develop spasticity. So we can't prevent it from following that course, but we can put them in braces overnight or during the day. We can start them on medications early in acute rehab or hopefully in acute care as soon as possible. And that will really limit how severe it gets. So there is the natural trajectory. We can't stop that without drastic measures, which would just lead to flaccid paralysis, which is probably an even worse issue. Like complete, if we just severed the nerve completely, right? But the interventions that I've talked about, I think if you get on top of them early, you can limit and prevent the complications from spasticity.
Mine's less of a question actually, but I just wanted to say thank you for the presentation here. Would love to see it become a mini series. I definitely got excited seeing your kind of teaser slide for the next part. But I guess the question part two, what I'm saying here is, would you say there's any other like case-based resources? Like I'm an M1, so especially starting off with our medical school education, what are the kind of like case-based resources would you say is out there that would be really helpful for somebody interested in PM&R? Like where do you kind of dig in there if you want to do more of this?
There's textbooks. I don't have anything off the top of my head, but if you email me, I can think about it and pull some together.
Perfect. Thank you.
Anyone else have any other questions? Gordon, I think it would be really helpful. I think for the oral medications, I think it's something we can all definitely look up on our own, especially for those of us going and doing away rotations. I think it's something really helpful for everyone to know. But do you mind just giving like the one liner for each of the common spasticity medications and like what would be like the common contraindication to using it or why you would switch somebody?
Yeah, absolutely. So I think baclofen is probably the first one that a lot of physiatrists reach for. Um, Baclofen, it's centrally acting, it acts on the GABA B receptors in the spinal cord. Um, it's good for spinal cord injury, brain injury. I would say a relative contraindication, it can lower the seizure threshold. So if we have a brain injury patient, they also often have had seizures. That's why I say brain injury. But anybody who has like a epilepsy or recent seizures, that may not be the first one you go for. Tizanidine, another good option. Tizanidine is an alpha-2 agonist, also centrally acting. The contraindications for tizanidine, it can cause lethargy more so than the other medications. Baclofen can a little bit too. I've seen tizanidine cause more lethargy though. Tizanidine also being an alpha-2, it lowers the sympathetic output, and therefore it lowers the blood pressure. So a lot of stroke patients and also spinal cord injury patients have orthostatic hypotension, especially early after their injury. So if we lower their blood pressure, that could increase their risk of syncope or orthostasis, which can increase the risk of falls. Tizanidine can also have some liver hepatotoxicity, so we need to keep an eye on their liver function tests, at least for the first 6 months to a year of prescribing. And then talking about dantrolene. Dantrolene is peripherally acting. I think Chris mentioned it. It just goes directly to the muscle membrane and inhibits contraction there. So unlike baclofen and tizanidine, it's not as sedating. It's not sedating. It shouldn't be sedating. It's probably a little bit stronger in terms of its effect on weakening the muscle. So a lot of patients will say they feel weak from it just because all their muscles are quite weakened. As opposed to the other two, it's more like the spasticity, I suppose. Dantrolene can cause liver failure, like fulminant liver failure. It's probably more rare than what you see with tizanidine, which is a more indolent liver hepatotoxicity, but definitely also something to monitor is the liver enzymes. And then I talked about benzodiazepines. Valium is one, or diazepam is one. really not what we want to go for because of their sedating effects, increased risk of falls. You guys might know about the Beers criteria, as a long list of meds, like Benadryl that we don't give to we try not to give to older people. So that would be wouldn't be the one you reach for generally.
Perfect. Thank you so much. That was great.
No problem.
Sorry, I had one more question. Um, so for spasticity, and you may have mentioned this already, but would you treat regardless of where the patient lands on the modified Ashworth scale? Like if they're a one versus a four, like are you treating? I know we talked about like there's some certain instances where you won't treat, but yeah, just wanted to see what your thoughts were.
No, I would say in general, if they're one or more, and the spasticity, but either and or is affecting their function based on the history you obtain, or on physical exam, you're seeing that it's causing problems for them, you go ahead and treat. The one thing I will say, and I didn't go into the Ashworth scale in like such depth because it's something you can read about, watch a video or whatever. A four is technically defined as rigid contracture, so you can't move the joint at all. So in that case, actually, you're not even talking about spasticity now. You're talking about the tendon has shortened. Maybe there's been some bone changes, and no amount of Botox, no amount of dantrolene, baclofen, whatever is going to change that. So in that case, they may need surgery, tendon lengthening surgery, or other joint surgeries to allow for increased range of motion. So yeah, we refer patients to surgeons pretty frequently. I think Penn probably has the biggest um, group in relation to that, but we'll do tendon lengthening surgeries or other manipulations of the muscles to increase the patient's range of motion, and that changes the anatomy too. Because you're moving things around, and in that case, ultrasound can be a really useful tool if you do go ahead and you want to do a focal injection because the muscles may not be where you think they are based off the surface anatomy. So just things to consider.
All right, very cool. Well, thank you so much for your time, Dr. Ridgeway and Dr. Stephen. We really appreciate the information and your perspective. Um, so yeah, thank you so much for your time.